Hello guys. This is Dr. T speaking. Thank you for joining me on this episode. Welcome to Clinical Medicine with Dr. T. I hope guys you're enjoying the content in the channel. I hope that you'll keep liking, subscribing, commenting and sharing. So today I want us to continue with the lower limb series. Yesterday I did neck of the femur fractures. So today I want us to talk about ankle fractures. Ankle fractures. Ankle fractures. So I want us to do ankle fractures in this video, and then we will do soft tissue injuries of the ankle in another video because they are very important. They need a separate kind of video. So here the soft tissue or the ligament injuries that I'm going to talk about will be related to fractures, but the video that I'm planning to do is going to be just isolated, like your ankle sprains, just like isolated ankle fractures, isolated sprains, sorry. Okay, so let's get to it. Just brief anatomy. So these are the bones that make up the ankle. Namely, it's the tibia. We have a tibia here, medial malleolus. We have a lateral malleolus. And then we've got a talus here, and we have a fibula here. Fibula. And then these three bones, they make up the ankle joint, and they are held together by ligaments. The ligament complex that you find on the medial side is your deltoid. The one that you find, there's a syndesmosis here, syndesmosis ligament, and then you find the three ligaments here, the anterior talofibular ligament, your posterior talofibular ligament, and your calcaneofibular ligament. So those are your ligaments there. The other ligaments as well, but those are the most important ones for our talk. So let's talk about fractures now. So okay, fractures, how do they occur? Ankle fractures, majority of the times they occur because of exaggerated or abrupt movements, ankle movements, like your inversions or your eversions. When those movements are done abruptly with a lot of force, they result in those fractures, ankle fractures. It will be someone who was just walking and then they try to fight the falling and then they fracture, or playing sport or running or whatever the case may be. So it's normally those are the mechanisms, but eventually excessive eversion or excessive inversion. It's not uncommon to find, or it's not impossible to find direct force that fractures one of the bones in the ankle, like gunshot. You get a fracture because of a gunshot, or because of a fall from a height, or because of what again? Because of direct trauma. Maybe someone hit you on the ankle and then they fractured your bone, or MVA, or maybe you were walking and then you were hit by a car and then you break your ankle, one of the bones in your ankle. So those are the different mechanisms in which you can get, but the most common ones are your sport related, movement related, that kind of a thing. And as someone who's working in A&E, you will find, if you work in A&E, you will find a lot of ankle injuries, be it soft tissue or just or fractures. And I think in a day working in A&E, I send patients to X-ray about five patients a day. That's how common these things are. Yes. Okay. So now let's talk about lateral malleolar fracture, like isolated lateral malleolar. Let me not say isolated. Let me say lateral malleolar fractures. So lateral malleolus fracture. When you talk about the lateral malleolar fracture, there's a classification there, the Weber classification, Dennis Weber classification. So when you approach a lateral malleolar fracture, you must think about a Weber classification. It must be in your mind, because it's going to help you to know what to do after making the diagnosis. So according to Weber classification, a lateral malleolar fracture that occurs below this level, which is the level where there's articulation between these two bones. If it occurs below that level, that's a Weber A. That's a Weber A ankle fracture. If it happens at the level of this articulating surfaces, it's a B. If it's above that, it's a C. And why is that important? This classification is important because it tells you about, so it's a lateral malleolar fracture, right? But it tells you about the possibility now of injuring the syndesmosis ligament. So if you've got Weber A, if I call you, I say that I've got a Weber A ankle fracture, by definition, I'm saying that there is no syndesmosis injury. If it's a B, it means plus minus, there might be, there might not be. A C, there is definite syndesmosis ligament injury. So B and C, because of the syndesmosis injury, these patients should be sent for an ortho consult. So that's about it. That's just about it with that. So if now a patient, these patients will need to be operated, right? That's why we're sending them. And it's at the discretion of when it comes to the B, because the B is a plus or minus, it's up to the orthopod. But in terms of the standard management, these patients have to be operated on. But obviously, the orthopod can look at other factors as well. But according to the standard procedure, they need to be operated. Okay, so now let's say you find a fracture. So you know, when you look at an X-ray, I'm not saying we will never make mistakes, but to minimize mistakes, when you look at an X-ray, follow the surface of the bone. Follow it, right? Don't try to snapshot the X-ray. You know, when you try to snapshot the X-ray, you will pick out, or you will pick up the obvious and miss the unobvious. But if you do it with patience and systematically, you are likely not to miss anything. So follow the X-ray. Don't try to focus on the fibula and also try to look what's happening this side. Finish with the fibula, and then come to the talus, and then come to the fibula. After you're done, let's say you pick up a fracture, it's okay, it's fine. Let's say you don't pick up a fracture, it's okay, it's fine. The next thing is to look at this space, because when you have got, remember, you cannot see tendons on an X-ray, but to predict whether there there's no, not tendons, sorry, ligaments. You cannot pick up a ligament on an x-ray. So that's why we've got this classification. It helps us. So we know that a C has got a Weber C. We know that a Weber C has got syndesmosis injury, but it's not because we picked that on an x-ray. We don't, but because of the classification, we know that once you've got a fracture above this, then you must be having a syndesmosis injury. So the same thing applies here. You will not see a torn ligament, but the discrepancies in terms of the space here will tell you if you are having, but we are going to talk about that. So follow the outer surfaces and then look at the space. Let's say now you've got a patient, but you cannot, they don't fall under the Weber classification. What are you going to do? When you have those kind of patients now, you need to say to yourself, okay, am I dealing with a stable ankle fracture or an unstable ankle fracture? And what do you mean when you say stable? There are three things that help you to decide if an ankle fracture is stable or not. First of all, displacement. If you have got an ankle fracture that does not, remember the fractures that are form part of the Weber classification are your lateral malleolar fracture. Weber does not say anything about fractures around here, like your malleolar, your medial malleolar fracture. Doesn't say anything about that. So you need to decide. Doesn't even say anything about where you've got a fracture of more than one bone. So this is what I want to help you with now, because not all ankle fractures you're gonna be able to Weberize them, put them under the Weber classification. That's what I'm trying to get to. So when you've got that kind of a situation, you say to yourself, okay, is that displacement or not? If there is displacement, then that fracture is unstable. If there is no displacement, then that fracture is stable. So it's enough to refer a patient for orthoconsult just because they've got a displaced fracture, whether it's medial malleolus or whether it's a lateral malleolus. The fact that it's displaced, it's enough to send. So because it's an unstable fracture. Number two, if you have more than one bone fractured, you need to refer, because if you've got more than one bone fractured, then that fracture will be unstable. So what do I mean by that? Let's say now you've got a bimalleolar fracture. Bimalleolar fracture. Refer this fracture. If you've got a trimalleolar fracture, refer this fracture. If you have got a displaced, I spoke about displacement there. Displaced medial malleolus, displaced lateral malleolus. Even if it's isolated medial malleolus, you refer because it's displaced. So displacement, let me not put it here. We spoke about displacement, and also if there's more than one. Number three, another thing that makes you to say a fracture is unstable is when you have got ligament involvement. Ligament involvement, be it your deltoid, be it your syndesmosis, as long as you've got ligament. Like a Weber C, we are referring a Weber C because there's ligament involvement there. I've referred a Weber B and a Weber C that is undisplaced, but because a B and a C, by definition, syndesmosis is involved, so I refer that patient. I've referred a couple of patients like that. So remember these three. So if your patient doesn't have any of these, and it's not a B, it's not a C, you can safely keep that patient and manage by yourself. Okay, so that's that. So now, let's talk about deltoid injury. How do you pick up a deltoid injury on an x-ray? Most of the times, when you send a patient for an x-ray, they will come back, their x-ray will be like this. When you want to assess for a deltoid injury, you need to look at this space and go all around. This space should be the same. So the distance from here to here should be the same distance from here to here and same distance from here to here. Once it's not the same, it means that we've got a Taylor's shift. A Taylor's shift. Most of the time, it's going to be a lateral one. Lateral Taylor's shift. So if you've got a Taylor's shift, it means that you've got your deltoid ligament is gone. So your deltoid ligament here is gone. So, but the thing is this, when you do an AP X-ray, you will be able to see your Taylors like that, like that, like that. But now the problem is that this part of the tibia goes like this. So you cannot see this space that you want to assess there. So if you have got a patient we have sent for an x-ray, you look at the bones, there is no fracture. But on the examination, they've got like tenderness, like severe tenderness on the medial malleolus, or they might even be having ecchymosis or bruising around there. Then they've got those fissures, but the x-ray is normal. Then you must suspect a deltoid rupture or a deltoid disruption. So what you can do, you can send this patient to the x-ray department again to have them do the mortis view or the mortise view. The mortise view is going to come back like this. You'll be able to see, you'll be able to trace the entire distance within that space. You will be able to see this. Unlike here, you couldn't see it. This is an AP. But a mortise view, you'll be able. A mortise view is like an oblique x-ray of the ankle. So now with that view, you can be able to see. By definition, they say this distance should be less than 4 millimeters. Once it's more than 4 millimeters, it means the ligament that's supposed to hold here has been disrupted, deltoid ligament. That patient must go. So basically, it means that when you see Taylor's shift, send the patient. Simple put. Okay, so after having seen that the patient has got a fracture, whatever, the next thing now that we need to make sure about is actually something that we should have done before when we were seeing before our patient goes for X-ray, is to do you know what the head of the department of orthopedics in UP, Steve Baker, Prof. Ngelwana, that guy is a father figure. We love that guy. He was a father. He was such a father. So he used to say that, you know, a policeman can pick up a fracture. Anyone can pick up a fracture. But what differentiates a doctor from anyone else is the fact that when a patient has got a fracture, you know the implications of that fracture depending on where the fracture is. So you know the implications. Like for instance, if you have a fracture, it's not enough to diagnose the fracture and say there's a fracture there, but you need to do a neurovascular examination. And he hated the phrase neurovascular intact. He used to get so irritated, especially with registrars. To him, he doesn't want you to say the patient or the limb was neurovascular intact. He wants you to say which artery did you examine. Like in the case of an angle, we need to comment about the posterior tibial. We need to comment about the dorsalis pedis and do the capillary refill and do a neurological examination. So you need to comment, you need to say, if you say the pulses were fine or the vascular aspect of the patient was okay, which artery did you examine? When it comes to now neurology, if you say neurologically the patient was fine, you need to say which nerve did you examine? And you must comment about the motor and the sensory aspect. So, for instance, if a patient has got a forearm fracture, then we need to hear about the radial pulse. We need to hear about the ulnar. We need to hear about radial nerve, both sensory and motor. Even the ulnar nerve, both sensory and motor. So that's what differentiates doctors from anyone else who still has eyes, who can see a fracture. So I'm not sure if I'm forgetting anything in terms of ankle fractures. Fractures. Okay, so guys, we will talk about sprains on another video because they deserve respect. So yeah, that's ankle fractures. Thank you so much, and stay blessed.